Good afternoon and hello everyone. Welcome to the Come to the Table Module 3, a Pediatric Primary Care Healthy Weight initiative sponsored by the National Association of Community Health Centers. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based on our Clinical Affairs Division here at NAC, and I'm pleased to bring you this event along with my division colleagues. Before we get started, I would like to make a few announcements. First things first, you've joined this online Zoom event. Just letting you know that this event is being recorded and this will be available for playback at a later time. Joining this session automatically consents you to this recording. If you do not feel comfortable being in this live recording, we do ask that you kindly step out of the Zoom room. But again, this event is being recorded today. Audio connections, you either use a physically called into today's meeting or use computer audio. Either option completely fine. I always advocate though, if you're in an area where Wi-Fi can be sometimes a little bit spotty, using the call-in feature typically is the best so you don't miss any of the content. But as I indicated earlier, today's event is being recorded. Mute and video have been disabled for all attendees. So that should be marked out at the bottom of your screen as you see in the image below. You should be able to, again, communicate with us via the Q&A box if you do need us. But again, the audio portion of your screen where you can communicate with us verbally has been automatically muted, as well as the video function. Q&A box located either in the bottom of your Zoom screen. You may have to take your cursor and hover over the box to wake it up, as I like to say, or maybe it's at the top of your screen. So again, you can find that Q&A box at any time and type any sort of comments, questions, or concerns into this box at any time. We will be answering questions at the end of today's event. If for some odd reason we cannot answer your question in the time allotted or need additional resources, we will reach out to you individually. Friendly reminders that again, that your audio and video have been disabled today. We encourage you to submit your questions throughout the Q&A box, and it will be open for the duration of this event, open currently right now. And at the end of today's event, there's going to be a pop-up window that comes up that lets you know that a survey is going to be distributed. Really, really important in regards to CMEs, but we'll talk about that a little bit later in today's session. At this moment, I'm going to turn things over to our speakers. So our first speaker is Jenny, so I'm going to turn it over to you. Jenny, the floor is yours.
Hi, everybody. Welcome back to those of you who are returning. For any who are joining for the first time, we're glad to have you. Today's topic is going to investigate the social drivers of healthy and unhealthy weight. We've been talking about obesity, overweight, and obesity as a chronic illness in children. And we want to look today through a lens that says it's not an individual failure on the part of a child or their family. It's not anything we want to blame individuals for in terms of having this as a chronic illness, which would manifest itself with things like fatty liver and high hemoglobin A1C, high blood pressure. We have also discussed the idea that BMI is not that end all and be all, but there's very close association with BMI in the obese and severe obese range associated with multiple chronic illnesses. So we want to look at what are the factors that are at play socially that are contributing to this. And for sure, they're some of the most significant factors. And there are factors that we can change, just like we can change and have seatbelt laws in order to reduce childhood death from motor vehicle crashes. We can implement systemic change around this epidemic of childhood obesity. So we're going to look at the social drivers of health, and in your health centers, what are you able to make an intervention around? We're going to focus a lot on food and nutrition security, and our second speaker, Kiski Bolton from GA Carmichael Health Center, is going to go in depth what they have done in their own program around that. But other social drivers of health are around the community and built environment, school. We'll talk a little bit about school, lunch, school placement, school, whether or not kids have PE anymore, that sort of thing, transportation, income, of course, childcare, and cultural norms. I want to say before we go forward, it was really interesting today. I got a publication from the National Academies of Health and Medicine, which I get regularly. And this one today is Proceedings of a Workshop in Brief, Defining Progress in Obesity Solutions Through Structural Changes. It's an 11-page document. We'll send it out with resources at the end. And it's all about this. And it's from convening expert panels and what are the ways that we can address solutions in obesity through structural changes. So it was very timely as sort of piece. So I'm interested in how any of you measure your social drivers of unhealthy weight and whether you have interventions. If you do, you can put them in the chat box. Next slide. I think most of us probably are aware of the two question for food insecurity. It's certainly been promoted by the American Academy of Pediatrics as being standard in pediatric care. And I know some of you use Prepare and some other instruments for social drivers of health. And food as hunger as a vital sign has really been something that's been promoted. So the two questions are, within the past 12 months, we worried whether our food would run out before we got money to buy more, yes or no. And then in the past 12 months, the food we bought just didn't last and we didn't have money to get more, yes or no. If you answer yes to either of those, you're food insecure. Obviously, number two is a more stark reality. But you can do often true, sometimes true, never true. And these have been really well tested, evidence-based kind of testing. They have a sensitivity of 97% and a specificity of 83%. So that means with sensitivity that you're going to pick up everybody, basically. That's a great sensitivity. The specificity is pretty good too, that you're really going to circle around the issue of food pretty specifically. So just on that slide, you can see there's school lunches, there's SNAP benefits, there's the little tiendas and grocery stores, and then a lot of people actually work in the food industry and have food insecurity. I worked with migrant farm workers for many years, and very few of them had control over their own food at their own table, despite filling ours. Next slide. So when we talk about food insecurity, how does it relate to health? Some people think that we're getting too socialized with some of our care, but actually for any doubters, it's directly linked to healthcare outcomes and to the economy. So the cost of food insecurity is $2,500 in family healthcare expenditures a year. This just came out in 2023 from Health Affairs. And there are higher healthcare costs for people who are food insecure versus those who are not, 20% higher healthcare costs. So if you want to make a plea to insurance companies or to anyone who's in charge of the purse strings at your health center on why you should invest in helping people with food insecurity, it has a direct relationship to overall healthcare costs. So that would include like emergency room cost, hospital cost, and your primary care center costs. So because of growing data related to this, Medicaid now, for instance, is paying for transportation to get food assistance, recognizing the healthcare implications. Next slide. Nutrition security is something different than food security. So you can be food secure and have lots of stuff that you got at a food pantry, although some people would say you're not food secure if you use a food pantry. But anyway, you could have lots of potato chips and potatoes and fast food, but that's not nutrition security. So nutrition security is being looked at more closely now, and that's around the availability of foods and beverages that promote well-being, prevent disease, and if needed, also treat disease. So we want to really emphasize nutrition security, particularly with children, as we go forward. Next slide. Another social driver of health that's been proven to have a significant effect on childhood healthy weight is the role of early childhood education. It reduces obesity through healthy activities, actually healthy food while they're there, structured days, opportunities for parents to work. It has been shown to reduce generational poverty and to reduce stress in the home, which is another factor that we will talk about. And I thought this was pretty amazing. I don't really know the details on the specifics of how they decided that it was reduced, but obesity and cardiovascular disease were reduced 30 years after participation in a multi-component early care program. I do know that there's great data on Head Start and early Head Start, and not only the high school completion rates, but also the overall health rates. So this again, we're learning more in recent years. We're paying more attention to these social drivers of health, and the references are there for you. Next slide. So school lunches, these have been in the news. It's so funny, like all this stuff has just been in the news in the last week or two since we were getting ready for this particular module. School lunches, pro or con. During the pandemic, we had pretty much universal school lunch made available, and people commented on how much it helped their family overall with their food security because they had money to spend on other food for their family during the week. And we also had backpacks going home with kids on the weekends. And I live near our high school, and we had lines of cars that would come to pick up school lunches that were prepared even while children were on Zoom. And we know that there was a big response that was a helpful thing. But when you actually look at obesity, there's some mixed information. So obesity was actually more likely in 29% of sixth graders if they ate school lunch. This is old data though, it's 2011, and there have been some changes. But that's a little concerning, right? And you can't necessarily link it to school lunch. It's just maybe it was also the free and reduced lunch. $2 billion were lost to school food programs in the pandemic. But people are making a case for universal school meals. And then there's a lot of variation in where you live. So Seattle, I don't live in Seattle, but I live in Washington. Seattle made a tax on sweetened beverages, which is different than school lunches, but it's another structural change, social driver. So they taxed sugared beverages, sweetened beverages. And they did find that there was a 20% decrease in the purchase of those beverages after the tax was made, but we don't know whether it was the thin people that were quit buying them or not. Like there was no relation to obesity. What they did do though, is they took the tax and they invested it in marginalized communities in the Seattle area. So the money was invested socially in areas of need, but it wasn't directly related to anybody's health. It didn't build a grocery store that was accessible, for instance. Next slide. So we have a poll question for you. Do you know locally the nutritional components of the school and vending machines in your community? And it's just a yes or no if you'd fill it out, please. And interesting for me, while I worked at an adolescent clinic that was part of a training program for adolescents, Job Corps. And they have a whole health and wellness curriculum, and their vending machines in the dorms were just full of awful stuff. I asked for a vending machine that would have healthy items and at least water in it, and it was denied by the administration. So it can take a lot of work to get those vending machines changed. Where I live in Washington, we do have only healthy foods in our vending machines at school. Okay, I can't see the poll answers, but if you want to show them to me, that would be great. So most of us don't know. So I mean, that could be a little homework assignment, right? Take a tour or call your school district and find out what the components are of your school and vending machine foods, and ask them while you're at it if they have a community garden in their schools. More and more schools are doing that. Next slide. So there's some really easy places you can start. Schools is an obvious one, okay? There are a number of ways that community health centers have worked on food security, and Kiski's gonna tell us theirs in a minute, but I just listed the partnerships that we already know about, okay? So Feeding America, that will get you down to very local places in your community of where there's food insecurity and where there's resources like food banks, food pantries, and you can make sure that your folks know at your local community health center. DoorDash, I listened to a really cool webinar, and you can look this up on DoorDash. They have a whole program on Primary One in Central Ohio is a health center, where DoorDash will deliver the food for reduced rate to any of your patients. So if you had some sort of food resource that you were trying to get to your patients, you can actually contract with DoorDash as a nonprofit. And they're doing this for nonprofits, and it's a pretty minimal cost. It is a cost, but it's pretty minimal. And they'll deliver diapers, they'll deliver baby food, they'll deliver whatever you want them to deliver. And I know my special needs clinic where I work, we often give the families diapers and stuff, but many of them take the bus. And yeah, we could sign up with DoorDash and have them do the delivery. So you can go on their website and learn about that. It's really neat. Food banks, most of us know about. Those are different than pantries. Pantries are your local things that have gotten parsed out. Faith communities have always had a strong role in this. We've talked about schools, libraries. There's a really neat Native Health in Phoenix has not only an indigenous urban farm, but they have a program called Read It and Eat. And the librarian comes to the health center, and they have all these little preschoolers and babies and parents, and the librarian I witnessed it. She reads a story about that promotes early literacy, and like carrots grow down, 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 beans grow round and round. I can still remember that from years ago. And then they have fresh food that they've gotten from a local grocer that has mostly been donated, and they make a meal together for lunch that includes some of the foods that are in the book. School program. It's very well attended. It's a lot of fun, and it's a social time for the families. And then the weekend food backpacks I've talked about. Lawndale Christian Center gives prescriptions for vegetables. They also have their own aquaponic farm and their own little grocery market that's next to their health center. Pretty cool. So those are some ideas for you. Next slide. That have worked, they're out there. There's many. If you have them, put them in the chat so we can learn more. Understanding the effect of stress on obesity. I'm just giving you all the highlights today. Kiski will go more into the in-depth on one model, but yes, stress, huge effect. And we can't pretend that we just have this family in an exam room and that we're focused in on healthy weight or good nutrition when we're not paying attention to the things that disturb it. And this is a biochemical reaction, and it's real. And stress increases cortisol, right? So that has an effect on your liver, and that makes your liver produce more sugar, glycogenesis, and you get more abdominal fat. And then your insulin gets used up, and your insulin levels go up until your pancreas burns out. But also anxiety, because it is a stress response, right? The fight or flight kind of thing. Also can increase impulsive eating. And we may not even realize that actually we are responding to our cortisol. It's not just that I like to eat when I'm anxious. Stress also really affects our sleep quality, and we know that hormonally we need that good good sleep to produce growth hormone and to help us with our insulin metabolism. And higher parent perceived stress has been very strongly linked with childhood obesity. So not to stress you out, but we need to be figuring out how we can relate this together with healthy weight programs that really also look at mindfulness, the sighing exercise we did, and behavioral health, and how does it all fit together? Is our motivational interviewing increasing people's stress response, or are we actually trying to do some motivational interviewing around stress reduction? Next slide. Oh, I forgot that this has bullets after it. Just go ahead and put them through. So yeah, so again, telling people that they need this heavy intensive program and not having it be available is an issue, but making sure that when we do make available a healthy lifestyle sort of thing, that we also have childcare available, that we have some availability for adults to deal with their mental health needs. Next. So Kiski Bolton is going to take us home here in the next section, and she is WIC program coordinator and has been participating with NAC's healthy weight intervention programs that do involve lifestyle interventions. They do involve the 26-hour thing, but they do look at social drivers of health as well and try to holistically look at the factors that affect the family. So I'm grateful that Kiski can join us, and I'm going to let her take it from here.
All right, thanks everyone. So yeah, my name is Kiski, and I am a program coordinator at GA Carmichael for numerous nutrition programs that all fall in the WIC category. So today, what I'm going to be doing is speaking to you about a combination of two programs that we have. We have a MEN program, which is a weight management program for children, and new, about 2 years old, is a food insecurity program where we created a food bank and started out giving out food prescriptions and as well as the food to our patients. And I'm going to correlate that to how we can implement some of those things into pediatric weight management and pediatric food insecurity. So next slide, or second slide. Okay, so a lot of times when we think about food insecurity, and myself included, these are types of images that we think about, you know, standing in line for food, getting donation boxes, you know, not having food at home or not being able to feed our children, homeless people. And those are people and images that do correlate to food insecurity. But I really think maybe not us, you know, all of us 98 people here on this call, but a percentage of the people that we work with, and especially who we serve, don't think of it in the right terms. So with the next slide, this is really the face of food insecurity. We are the face of food insecurity. Even some of the people who are on this call today, and sometimes when I go to the grocery store, I feel food insecure because of the prices. But you know, the elderly, college students, single parents, small families, young families, all of the people that we interact with every day that come to our clinic or maybe don't even qualify necessarily for some of the programs at our clinic, but are living in that no man's land, which I was on the call today, I think Jessica's on here, where I kind of talked about that because it was just happenstance, but we usually serve people who are below the federal poverty line or at the federal poverty line. When you're looking at Medicaid or school lunch, or WIC, it's at 185% of the federal poverty levels. CHIPS, I think, goes up to 210 or 215. In Mississippi, pregnancy Medicaid is more generous to like 230% of the poverty level. So we're thinking of people like that, and that's correct. But when you think of who's actually food insecure, it's a lot of times the people who are above that level, because at these levels, especially 185% of the poverty line and below, there's programs, there's food stamps, there's you know, income-based pantries, There's things that they can qualify based on their income to receive assistance. And sometimes the assistance comes with education and follow-up. But for people who aren't in that zone, they're a little higher, there's not a lot of help. So what we want to do is capture those people as well as the ones that are below. So next slide. So how do you do that? The traditional definition of food insecurity and the full definition, which I think Jenny covered pretty well, are listed here. But when we talk about the total definition of food insecurity, we're thinking about anything that's disrupting a person's food intake and eating pattern, anything that may be decreasing the quality or quantity of food, and that may be because of lack of money, which is what we think about. But it's also lack of access. So we think about food deserts or transportation, or it can be lack of knowledge. You may have the money, but you just have no idea on what to do. I was telling them in a previous meeting that I have been on home visits to patients that live next to a farm. They live right next to a place where they can get fresh fruits and vegetables, and it wouldn't have mattered if I picked the food and took it to their house. They would not know how to prepare it. So, and they would probably default to something cheaper or easy. So there's a lot of things to consider when you think about food insecurity. So next slide. So the programs that we had, I mentioned, targeted actually HIV patients. So those HIV patients come to our clinic for the Ryan White program. And a lot of times they are very food insecure because they live with a double stigma where they may be low income, but they also don't want to tell people about their status, and they don't take advantage of some of the programs that are out there because they're ashamed or they just want to keep their business private. So what we did was we created a food package based on their comorbidities outside of HIV, which most of the time were high blood pressure or diabetes. We created a low sodium and a low sugar package that we gave them and followed them for a year and took their labs pre, mid, and post to see if there was any improvement in their lab work based on what they were eating, which was usually a box that we gave them bi-weekly. So that's one program. The second program is a weight management program that we have for children where we do taste testing and intervention physical activity. So taking that information and putting it together as to how we can tackle food insecurity in children, the most important thing that you have to do is identify who those children are. And that can be a little bit more daunting than you think because we want to remove the stigma. So sometimes what we do is we may ask questions about, parent, what is going on with your child? And if we know anything about the constituency that we provide services for, is they are sometimes fearful of the man, authority, people in charge, especially people who may be in healthcare or social services. So sometimes we're not going to get accurate information from them. So some things that you can do to consider that is to make sure that the right people are asking those questions. Maybe they're afraid to tell the nurse that their child's not eating properly. Maybe they'll tell the finance person or the billing person or the front desk person because they see them as a money person, but not a person who has any authority over decisions made for their children. Maybe they'll speak with a community health worker, but not the social worker. So there's more than one type of person that can give out these insecurity questionnaires. And also we think that we want to have a familiar face, but when it comes to very tough questions or personal questions, sometimes it's better to have an unfamiliar face, because when you think about the community health center as a whole, most of the time, the people who are working in the health center are also living in the community. So I don't want to tell my church member that I'm having a hard time feeding my child, or I don't want to tell the lady who's in Girl Scouts with me that I'm having a hard time, but I'll tell this girl I've never met before. So sometimes it's important to say, okay, I know I got to give Mary this questionnaire, but I know her pretty well. Would you do it for me or something like that? Because you may get better answers. And you have to consider that fear that parents may have, that caregivers may have, or that elderly people may have when they're filling out this form. We want to use plain language and validated screening tools. Jeannie mentioned some of the screening tools I'm already going to show you, so we're just going to breeze through them. So the next slide. are just examples. So this is the USDA food insecurity screening form short form. It's very short. I want to say these are all the questions. I can't quite remember. It's been a long time, but these are just some examples, and some of these were already on the slide she had. And so the next two slides is also the USDA questions, which are 18 questions, and this is called the long form. So things to consider with that is, can they fill it out on their own? Because it's really wordy. Do they need someone to ask the questions and simply mark the answers? Do they read well? If they speak another language but speak English, just because they speak the language doesn't mean they read it. And I found in which we have a high Hispanic population, so just because they speak Spanish doesn't mean they read Spanish. So you really want to make sure that you're not letting them see the word no and they're just circling no, 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 no. Next slide. And so what I just showed you was the USDA. When you get these slides, or I can send Naomi the links, but these are the two links to USDA, which has great questionnaires, and then Tufts University has really wonderful resources and validated questionnaires that they have that tackle food insecurity, hunger scales, and those that are geared to people who are Latin American. And next slide. So, of course, Jeannie already kind of talked about this too. Jeannie was all up in my presentation, but the cycle of food insecurity is kind of, I feel like, how America has gotten to where it is. So this is a slide from Feeding America, but there's like just a revolving circle of what happens to us, which is we have less money for nutritious foods. That's definitely going on right now with the inflation that we're experiencing. The less money, or in this case, knowledge or access, gives us a lack of nutritious foods. It results in either poor disease management or the development of diseases, or obesity, which is now actually a disease. And those things can contribute to increased health complications, medical care, medications, decreased mobility, which all have increased expenses, whether it's missing work, paying for medications, going to the doctor more, transportation for the doctor, and then you have less money. So you're just in that cycle of where you can't dig yourself out of it. So when we look at the next slide, this is where we come in. We want to get them out of that cycle. Now, this is just an infographic that I've been using in a few presentation. It says diabetes, but you can insert any disease state there that you like. Most of the time what happens is a person's food insecure, they develop diabetes or some other medical problem, and then at some point they get around here where you see that blue line that says traditional clinic intervention, which is where most of us are in a clinic or a community setting. And we do what we do to treat it. And sometimes over time, they end up going to the hospital and everything keeps going in that cycle. But when it comes to pediatrics, we have a unique chance to stop that cycle before it starts, because when we see and recognize food insecurity, we can do the community intervention. On the screen, it says food banks, but that can be any community intervention that will work for the family and work for your organization. So this is where we want to be. Okay, next slide. So I already said what the full definition of food insecurity was. When we take a deeper dive, we want to make sure that we consider the barriers that are keeping people from eating nourishing foods. It's not always money. It's these things we've already mentioned: transportation, availability, knowledge, money, of course, skill, literacy levels, and traditions. Next slide. So what can we do? You know, I can't take people to the grocery store and shop for them out of my budget. So we've got to figure out some things that we can do that we can afford within our programs that will help. And some of that is real basic. It's just good nutrition education. Some of our patients have access to WIC. They have access to food stamps. They have access to food pantries, but they don't know what to do with it when they get it. So the easiest and cheapest thing we can do is provide them with good nutrition education so that they know what they can do with the foods that they have access to. Of course, screening them, which we've been talking about, and doing an intervention, which is either referring them to programs, starting a program, or educating them on ways that they can make changes and improve. Next slide. So again, Jeannie already said it, but consider a provider prescription. So whatever the magic is that a doctor can say, that a dietitian can't say, or a nurse can't say, or a community health worker can't say. A lot of times, if a patient gets something from a doctor handwritten out, signed on an official letterhead, they're going to try to do it. It may not be long-term, but they'll try to do it. So creating a prescription for what they need to eat, it doesn't have to be anything extensive. It can just say each day eat 5 fruits and vegetables, and read your label and get 25 grams of fiber or something like that. But something like that is really invaluable and can help. Make sure that you've already screened your staff for food insecurity. Your staff may be food insecure. You do have doctors and dentists and other health professionals working there, nurses or RNs who are making probably a decent salary, but a lot of our support staff, depending on family size, even on professional staff, they may be food insecure. And you want to address that with your staff first so they can then help others. And involve and educate your surrounding community members so they know what services you provide and the access that you have so they can make referrals to you. Next slide. Other things that you can consider, which Jeannie says some of these as well, are supermarket tours. Most grocery stores love for dietitians or other health professionals to come and do supermarket tours because they're going to get some business out of it. But just navigating them around the grocery store so that they can see how everything works. You would be surprised at how many young millennials and then whatever these new generations are that are coming behind them don't really know how to go grocery shopping. They don't know how to shop for a week or shop for a family. They're only kind of focused on the meal at hand, and they can't put together, a grocery shopping trip for a week. So these things are rooted in home ec. They're rooted in things that used to be required in school that are no longer required. As the world we live in, it pushes more to technology. A lot of things like that have gone away. I think more people are picking up on it during the pandemic, but we're out of that now and people feel free and have reverted back to some things. So community gardens have been around for decades. Some non-traditional ideas is to hire a caregiver. There's a community health center in Mississippi here who they have the garden space, they have the land, they don't do any of the work. They have a small $5,000 grant that they use every year. They hire a caregiver and they hire master gardeners. And of course they have volunteers, but they do a full harvest of like corn, potatoes. They have a crop every season that comes in. And when it's harvested, they just put it all in the lobby and people just come and get it. There's always something in there that people can come and get. There's no questions asked. There's no forms to fill out. It's just food that people can eat and they can take home as they like. Consider involving your cooperative extension service in your state, land grant universities, schools that have ag majors are always looking for things that they may want to do for their thesis or their PhD or things that they're doing. And they're lots of time bunching up and redoing the same work over and over again. But if we reach out to them, that could be a great opportunity for them and us. Shopping cooperatives where you may buy a Sam's Club membership or a Costco membership and pool your money together and buy things like that. This blessing box here in the picture where it's just a little mini food pantry. We have some in the area and they stock themselves. People take, people give. It's all free except for the space and the building. And then I also had a presentation where I did a lot of talking on food deserts. We didn't talk about that here, but one of the things that some of the stores that I talked to in the area that have very limited fruits and vegetables said that the reason why they don't have them in stock is because people don't buy them. So if we really get with our patients and implement change and ask them to change, stores will follow. They're gonna stock their store with whatever's gonna sell. So as they buy more fruits and vegetables, they'll stock more fruits and vegetables. That's the end of my presentation. If you have any questions, you can drop them in the chat and I'll be more than happy to answer them. But I appreciate you guys for having me today.
Kinsky, that was spectacular. And I'm sure we have questions. And all I did was hit the highlights and you went, yeah, you're getting applause. You you went deep with so many of those things. We both talked really fast, so we have lots and lots of examples, but it's up to all of you listening to, oh, look at all that love coming your way. It's up to all of you listening to do the implementation part. That, of course, is way harder. And hopefully you'll be able to go back over this several times if you need to. I would encourage you to pick one thing to get started. If you're not screening for food insecurity, you could do that. I totally love the idea that like the financial advisor might be the right one. I'm with you 100%, Kiski. I don't want to tell somebody I know whether I have depression or whether I'm stressed or whether I'm struggling with, you know, a whole number of things. I will tell my provider, but it will take a lot. So I love how you've really talked about sometimes it's the unfamiliar person who feel, as long as they feel safe, they have to be not scowling at you as the financial person, but they have to have a welcome, open attitude, right? So I love that. I'm going to turn it over to the questions. I'm going to give one example that was an eye-opener to me very early in my career. I was a very young mom, and my husband was a very gung-ho, he still is, very gung-ho helper who had nothing to do with healthcare and pediatrics, but we worked in a migrant health clinic, and we had a mom who had, she's African-American, she'd grown up in foster care, she always wanted to be a mom. She had run away when she was a teen, she had never had a mother figure. She had these two adorable kids. She had a lousy partner who ended up being gone, and by the way, had HIV. And so we kind of adopted, the little girl was my patient, we kind of adopted the family. And as they got transitioned into some good housing, public housing, my husband went and bought all this stuff for her kitchen. And he gave it to her, and she looked at a spatula and she said, "What's this?" And he said, "Oh, that's for like cleaning out the mayonnaise jar." And she's like, "Oh, well, she'd never had anything like that. What's this?" They were measuring spoons. And he goes, "Well, like if you make a cake or something, you need to know like what to measure out." And she looked at him, and I was just like, she's never made a cake. She had very low literacy. The only cooking she knew how to do was with a microwave or on top with a stovetop. That was it. And she had never read instructions. She couldn't to make a cake, nor did she have anybody model that. So starting where our patients are, in a helpful, kind way, right? And that's why I liked Read It and Eat, because they would take these vegetables that a lot of people had never done anything with, and they'd show them, oh, you have to peel how to do an eggplant, or you have to peel this, and then making it together, and it became participatory and fun. So that's just an example I have, but I'll stop there.
I'll add to that, just not to take up enough too much time, but I was very young. I know I look young, but I'm kind of old. But I was very young working at the for the health department a long time ago, probably 2007. And it was like my first job, and I just loved everything about everything. I loved everything. And I had a patient who had a little girl whose iron was very, very low, like to the point that she may have to be hospitalized. Her iron was so low. And the mother was just really, really gung-ho on trying to get her iron up. She was a great mother. And so I got my little info pamphlet out and reviewed with her. We have pamphlets on low iron, all of the things she should be doing. And she's saying, yes, I'm doing that. Yes, I'm doing that. Yes, I'm doing that. And I got down to dry beans and peas because that's a part of the WIC food package. So she said, well, I give her give them to her, but she won't eat it. So, me being the Southern girl I am, I'm telling her how she can cook the beans and peas and make them taste delicious. She's like, oh, well, I do that. I know how to do that, but I don't give her those. I give them to the way you guys say. So I'm like, I'm saying, well, which way are we telling you to do it? She was literally going by what the paper said, dry beans and peas. She was giving her little girl the dry peas from the package and cooking them for the rest of the family because she thought that if she gave them to her dry, that it would help her iron go up. And
oh my goodness,
it just took me so long to gain my composure because it never crossed my mind that you would have to say cook it.
Yeah, right.
We can never ever assume anything with the patient. That taught me a valuable lesson very early on, to elaborate every point, because you don't know. People are gonna clean their kids up. They're gonna be nice and shiny when they come to the doctor. They're gonna be clean. They're gonna, most of the time they are. You can't judge on how they're dressed or how they speak. You have to break it down, because you really never know.
Very true. And back to motivational interviewing and confidence scales. How would you cook this? Might be a question to ask our patients, right? Just to find out. Patients gave me this huge bag of field peas in the South when I was at the Migrant Health Center. I'd never seen field peas. I thought they were green beans. So I brought them home and I sauteed them. And my husband, who's from the South, went, that's not going to work. And I was mad at him. So I was like, yes, it is. And oh boy, those were so bad. And then I understood why they gave so many, because you're supposed to show them, and then you wouldn't have as many. So even, you never know what people know. Let's go to questions. Naomi, I'm looking, but I'm not seeing questions.
Jessica Haas has a question. She was questioning about the food screen. Is it outside of the regular social determinants of health screen? We use NextGen in our health center, have used it, I think, ever since I've worked there for 10 years. So we have a screen, which is not the same thing as this USDA screen. If I were you, I would find out if the screening form that you're using for the social determinants of health is validated. How often is it picking up people with food insecurity? If it's not picking up a lot of people who are food insecure, it may not be the best tool. Working in a clinic myself, I do not want any more sheets of paper. I don't want any extra work to do. I don't want to see not one more new program. So I understand that you want to keep it simple, but this is a good thing that you could do for students or interns or something like that if you want to add to your food insecurity questionnaires. But I think that you need to speak with your medical director or IT staff to see if the screening that you're using is a validated screening for food insecurity. And also that USDA short form is 6 or 7 questions. So it may not add a lot of bulk to the workload.
And the 2 question screening form is part of American Academy of Pediatrics materials. If you use those, it's also in the prepare screening. If you use that, PRAPARE is how that's spelled. Other questions, comments, or ideas that any of you have? And if you put your name in the chat, possibly we could even open up your microphone. I'm not sure. But use the chat and let us know if you've got things that you want to share.
If you want to ask a question in person, you can use the raise your hand feature, and we'll be able to unmute you.
And while we're doing that, would Naomi or Alyssa, would you please explain the CME? Because I know people have had questions about that.
Yeah, so I can take this. Hello, everyone. My name is Naomi Smith, and I'm a project manager at NAC. I know a lot of you have been having questions regarding the CME. Like it's stated in this slide here, you do receive 1 credit, but you do need to sign up, or excuse me, fill out the CME survey link, which will auto-populate as soon as the session is over, and then you will be guided to a Qualtrics form, which you'll submit, and then you'll get your CME to your email that you submit through the form. So hopefully that answers your questions. If not, my email is on the slide listed above. So if you have any questions, please feel free to reach out to me. Thanks.
And if you're watching this in a recorded version later, so none of you at the moment, you just need to email Naomi for the link to the survey, and that'll be available until June 30th.
And another thing,
and it's honor system as always, right? An hour You get an hour credit. So no matter how long this takes you. What were you going to say, Kiski?
When we're referring patients to food banks or food pantries, I would, especially if it's in the area, visit that place, to see what they have available. As you mentioned in your presentation, just because they're getting it from a food bank doesn't mean it's healthy at all. A lot of times these places are getting donations from stores. They're getting things that haven't sold. You'll see all sorts of new products that, like there's like this new macaroni and cheese or this, all sorts of things that we see in the store that we may not buy because it looks weird or strange. Sometimes when those things aren't purchased, they go to food pantries. So it's not like when a person goes to a food pantry or a food bank, they're going to get meats, fruits, vegetables, things like that. They're going to get what's there. It may be a wonderful place that has all sorts of options, and it may just be a place where people are trying to do good, but they're just receiving whatever they're receiving. So you really want to kind of have a picture of what you're sending a patient to, so they'll know what to expect. Because if they're getting a referral from us in the health side, they may assume that whatever they get from there is healthy.
And I want to say something about power drinks, Gatorade, those energy booster things, and drinks in general. Our families really are not well educated on the nutritional or lack of nutritional content of those, and they do add a lot of needless sugar. So when we talk about no sugar drinks, we're including things like Gatorade, sports drinks. Water is your best hydrator. I did live in the South. It's your best hydrator. It's pretty unusual that you actually need something like Gatorade unless you're throwing up and, vomiting and having diarrhea, and then there's Pediatric. So I think the more that we can help families understand how much money they can save if they just drink water, and then low-fat milk, if the child tolerates that, we can go a long way.
All right, Walter has his hand raised, so I'm going to.
And Walter, you've been one of our high participants and contributions, so thank you.
No, thank you. And it's a great presentation, both Kiski and Jeannie. So thank you for this. I just wanted to mention real quickly that the FDA's new food code, it finally addressed food donations, because I know, especially from retail, sometimes there was always a reluctancy to donate food just based on legality. So just wanted to throw that out there, that was just recently added to the 2022 food code.
Can you tell us a little more about what the
Well, they never said you couldn't do it, but people are always concerned about legality. So if you're donating food, what would the legality be if somebody got food poisoning, for instance? And I was working in acute care, and we'd always have a lot of food, and we'd have different places asking us for it to give to different people. And we wouldn't do that because we weren't sure from a legal standpoint what our how that would affect us. So now that they at least mention that as long as you follow safe practicing guidelines, the food safety guidelines, that it's okay to donate.
That's great now.
No, it is, because
Wonderful.
I know that, a lot of places. And I'm glad you mentioned about the drinks. That's really important because so many people are eating Gatorade or even the energy drinks. And, do they really need it and all those calories? So thank you, and great presentation again. Thank you.
Thanks. I had one boy that was trying to lose weight and be healthier, and he was drinking like Ensure or something like that on top of eating, thinking that was gonna help him. And so he was consuming even more in his attempt to consume less. I also had a boy ask me whether he was the right size, and he was a little chunky. He was an early adolescent. And I was like, yeah, you're good. He goes, well, he was getting a football physical from me. I want to play. And I said, yeah, you're good. You're good. I said, why? And he goes, well, I'm not sure if I'm eating healthily or not. And I said, well, tell me about what you eat. And he goes, well, it's kind of whatever we can get. So did they fill out the food insecurity thing? No. So he tells me, turns out he's living in a literal tent on the side of a river for the summer. Now school's starting and he's going to have a different place to live. But he was homeless, and he was living with his uncle in a tent. So no, he didn't have good food, and he was worried that he wasn't going to be healthy. So yeah, I mean, you uncover that with 5 minutes left in an office visit, right? But that's where I think asking the questions, tell me what you are eating and we can talk about it.
A good rule of thumb that I use with my own children with patients is Gatorade was created a long time ago by the Florida Gators for their football team to replenish them. And I always tell them if they're not working like a Florida Gator football person, then they don't need to drink the Gatorade. If you're not out there running reps and pushing whatever and tackling people, you do not need Gatorade or Powerade.
And I'm giving a shout out to Sherry, who I worked with in the past. Yes. All right. I think we're ready to wrap up. Are there any other last minute questions or comments? Happy for your comments.
I see one. Are there any good resources / screening tools to assess for food literacy?
As in, do you know how to cook and do you know how to read as item on read a recipe?
No, I don't think there are. I'm a member of the International Health Literacy Organization, which is working on that. They have a nutrition section. We're working on some things like that. But the best way to tell that is to actually just screen them for health literacy. And if they are generally health literate, then they should be able to interpret anything related to health, which would be cooking or nutrition. But there's nothing that I can think of that does screen for that. And because it's so broad when it comes to cooking and things like that, but no, I would just kind of go with the health literacy screenings.
Thank you, Kiski. And I read in terms of health literacy that even, I'm gonna single out physicians, are happy to get low literacy material, like we're not offended. So there's no reason to make material high literacy. All right, we're gonna wrap it up and say thank you to all of you. Go eat something nutritious and give yourself a pat on the back. Kiski, huge thanks to you. That was spectacular. I really appreciate it and would love to see you in action in Mississippi. If you have questions afterwards, feel free to send them and you can do your CME and we're gonna sign off. Thanks, everybody.